missing. Dr. Sagher thought it's probably been 8 years since he was with us. I'm a little remiss in not looking that up, Doctor, but I would think it's at least been 8 years. As I had in the notes, Dr. Sagher has agreed to talk to us tonight about the TN procedures performed at the University of Michigan, Go Blue, and handle questions and answers. Both Lynn and I think I mentioned to you, have children that are graduates of University of Michigan. So we're proud to have you. And he's going to talk about the various options available at the University of Michigan and the advantages and disadvantages of the various procedures that they perform. A doctor did take a look. I was quite impressed. He took a look at Dr. Schwab's presentation from last month, and he said, "Holy Moses, he's covered a lot of what I was going to cover." So, but I felt that still University of Michigan is held so high, only 60 miles from most of us here, and a number of people that I know prefer to go to University of Michigan rather than Beaumont, DMC, or Henry Ford because they have doctors they prefer and love at the University of Michigan. So I felt it was still worthwhile to have him with us and to share what is provided in Ann Arbor. So are you going to predict the football team at the end of your questions and answer, Dr.
Not a chance.
I'm
going to stay in my lane.
See we can go ahead. I'll let you kick it off. Thank you.
Right. So thank you, Tim, for re-inviting me. It's been a while, as you said, but I did enjoy meeting the folks at and I think it was at Beaumont when I was invited there, and I actually learned a lot from you all as well. I realized that hold on a second. Never fails. And I learned a lot from you all because you guys have been very engaged in this, and this is a great group. I've actually referred a number of people in my clinic to your group because I was so impressed with the sharing of information between folks. I think it's quite helpful. And then when I took a look at Jason Schwab's presentation, as I mentioned to Tim, it's like, this is pretty clearly similar to how I approach trigeminal neuralgia, and I don't know how much appetite the audience will have to hear my thoughts about it, given the fact that many of them will parallel what Dr. Schwab's are. But he encouraged me to continue along that line. Having said that, if I am boring any of you, please interrupt me. We can go on tangents. I realize that many of you have been through this journey with trigeminal neuralgia for a number of years and have heard and have read and have listened to a number of people and opinions and data and research. So this is not new to you. Still, I see about 5 to 10 trigeminal neuralgia patients a week in clinic. And I'm struck by just how much education needs to happen for people with facial pain, and how much I derive a lot of satisfaction to teaching them how I approach this and how I approach the various procedures and how I rank them in my mind for any particular patient. So this is a very personal talk to me because of the fact that it reflects kind of how I think about things. So you don't necessarily take this as gospel. Take it as my opinion in terms of how I approach somebody who comes into my office with facial pain. And again, if you have questions, please do interrupt me. And let's see, I'm going to share my screen here and tell me. Let's see, I'm going to play here. Does this project okay?
Perfectly.
Okay. So this is, as this slide says, a surgical primer. This is how a surgeon who does trigeminal neuralgia thinks of trigeminal neuralgia. There are three main questions when it comes to somebody who shows up in my office with facial pain. Is why do they have the pain? When should he intervene, and how he should intervene? Those are the kind of the guideposts that I use in terms of how I advise patients to go forward. The most important thing to remember about trigeminal neuralgia is it's trigeminal. A lot of people who have facial pain have pain that's not necessarily trigeminal or not strictly trigeminal. They have pain in the back of their head, they have pain in their neck, they have pain inside their ear. That is not trigeminal neuralgia. It's still pain, but it's very important for the surgeon who sees you in the clinic for your facial pain to really understand where the pain is, because it will dictate how successful or not the intervention will be. So the anatomy of the trigeminal nerve is extremely important, as you probably already know. And I don't know if my mouse, I don't know if I can see my mouse even. In the picture on the left, you can see the way the trigeminal nerve is behind the eye, kind of branching down to the jaw, into the cheek, and above the eye. These are the three main divisions of the trigeminal nerve, and we typically call them the supraorbital, the infraorbital, and then the mandibular. So these are, in common parlance, V1, V2, and V3, and you probably are familiar with that. V is for the trigeminal, the fifth nerve, and the 1, 2, and 3 go from the forehead down. And very, very often, trigeminal neuralgia will involve one or more of these divisions, always on one side, never simultaneously on both. I know that some people have ping-ponging pain. Some had pain on one side, and some years later on pain on the other. But pain that appears simultaneously on both sides is a real problem for the diagnosis. It really is a unilateral diagnosis, and it affects one or more of these distributions. Most commonly, the second. So the most common trigger point is the one below the nose, over your top lip. But you can have triggers, on your tongue. You can have triggers in your forehead, and so on. So other triggers do exist. So what is it? And trigeminal neuralgia is one of those things that is completely clinically driven. In other words, I don't know if somebody's facial pain is trigeminal neuralgia until I talk to them, because the description of trigeminal neuralgia pain is very, very stereotypic. Almost everybody will describe it in the same way, or at least at some point in their lives it was in the same way. These are paroxysms, attacks of pain. They're lightning-like, they're electrical, they're jolting, and only in the face, as we discussed. And you can have it both spontaneous attacks and triggered attacks. So this is trigeminal neuralgia. Sometimes it's called classic trigeminal neuralgia, but this is what we typically look for when we make the diagnosis. Understanding, of course, that there is an evolution of this pain, and we can talk a little bit about constant pain and burning pain and things of that nature. But at its outset, when somebody first has an attack of trigeminal neuralgia, almost always like this, it comes out of the blue, it disappears into the ocean, it goes away, and it may not come back for a while, or it may just keep coming back. And that's how trigeminal neuralgia almost always starts. It's almost always relieved by Tegretol, like Trileptal, at the beginning. In fact, if somebody was started on Tegretol at their first attack and it didn't help at all, that's a real concern that may not be dealing with trigeminal neuralgia. So it's really almost a sine qua non, kind of almost definitional, if you will, for the condition. So what causes it? That is the age-old question. We really don't know yet. We believe that there are some pieces of evidence that suggest that the nerve itself loses some insulation where it's being compressed by an artery, and this is what the microvascular decompression is all about. It could be loss of nerve insulation related to MS, or we don't know. I mean, and that's the bottom line, is that now, over 60 years or more into our understanding of trigeminal neuralgia, we still don't know why some people get it and some people don't. One of the things that concerns me when I see people with trigeminal neuralgia is they believe that if they have a blood vessel compressing their nerve on an MRI scan, that means they have trigeminal neuralgia, where it's been shown that fully 40% of people with trigeminal neuralgia will have compression on the other side as well with no pain. So that's not necessarily the cause. We think it might be the cause, but there's more to it, is my point. And just having a compression doesn't make the diagnosis. So the question is it trigeminal neuralgia? And that's a really difficult question sometimes to answer, because everybody's story is a little bit different. We rarely see a surgeon's patients in their first attack. We usually see them 5 years, 10 years down the line. And by then there's been an evolution of the pain syndrome. Things have changed. They may have had other procedures. So it sometimes is the waters are a bit muddy. But this pie chart is just to let you know that of all facial pain, trigeminal neuralgia is roughly 10%. So we sometimes conflate the two terms, but we're ignoring 90% of patients with facial pain by doing that. And so I know this is a decision that the Facial Pain Association made a few years ago, was to change its name because they realized that they really weren't serving the majority of people who suffered with facial pain by just calling it Trigeminal Neuralgia Association. There's a lot more to facial pain than just trigeminal neuralgia, although again, the focus of my talk initially will be on trigeminal neuralgia. And when you make the diagnosis, then you're faced with this soup of things that you could try, whether it be medications like, Tegretol, Trileptal, Baclofen, Neurontin, Lyrica, others, or there's a bunch of procedures that we do, nerve injury procedures, neurectomies, balloon compressions, gamma knife, radio frequency, and then of course the microvascular decompression. And a lot of the patients who come to me are just confused. They don't know what to do. They don't know what to do next. They don't know where they are with respect to the treatment paradigm. So I thought, as we, discussed it this evening, I'll kind of give you my approach to it. So when do we consider surgery? Well, there are two main reasons to consider it. First of all, can't tolerate the medicine. So you probably have a number of people in your group who've tried a number of these medications, and the side effects can be intolerable. And whether it be unsteadiness or sleeping, or it could just be the liver enzymes or white counts that are dropped down, or the sodium that goes down to the toilet. So a lot of times medication works, but you can't take it. And then the other issue is that some medications, although initially successful, eventually they lose their benefit. And that's another reason why people would consider surgery. But somebody came to me, let's say if I had a family member with trigeminal neuralgia, just started having it a week ago, I would never advise them to have surgery at that point. That's not the right move then. The right move then is to see if medications help, and because oftentimes medications will help for years. and sometimes we'll never see them for surgery. So we really want to wait, until medications or to see if medications lose their benefit. But then we talk about the surgery. So there's lots of them, right? There's the MVD, of course, which some of your group have had. I've heard you guys mention it. But there's other things. There's radiofrequency, there's the balloon compression, there's glycerol, there's a gamma knife, and then, of course, there's an neurectomy. The MVD is sort of the granddaddy of the procedures. It's the biggest operation that we do for it, and the one that most of the vascular trained neurosurgeons will end up doing. And it is taking advantage of the theory that there is a loss of myelin on the trigeminal nerve, which you see over there. This is a microscope image from a microvascular decompression. You can see, I hope you can see my arrow outlining the trigeminal nerve. And right next to it, there's an artery. And if you can see, as you move the artery away, there's a groove in the nerve. You see that? Mm-hmm. So in a decompression, what the surgeon will do is they will move the artery away from the nerve, and either transpose the vessel or put a piece of Teflon between the two, in order to prevent the vessel from pulsating on the nerve. A lot of patients ask a very good question of, why doesn't the Teflon cause pain, right? If it's a compression thing, you're not really helping by adding something there. It's still going to compress the nerve, and that's a great question. The thought behind it, the efficacy of this, is that the thing that's causing the pain is the pulsation and contact between the nerve and the vessel, not necessarily just the pressure. So it's not just mere pressure; it's the pulsation and the actual physical contact between the artery and the nerve. So the steps in this operation, these are borrowed from some articles and books that I came across. So not everybody's incision is going to look this way, but basically it's all behind the ear. We make an incision there. You essentially take a circle of bone out from behind the ear. You then open the dura, which contains the spinal fluid and the cerebellum, and you push the cerebellum gently aside to expose the nerve. And the nerve, I lost my arrow again. You can see the artery there is kind of like a bucket handle on top of the nerve, and that's where the compression is typically seen. And then you put the Teflon. So this is kind of a schematic showing you how the typical microvascular decompression is done. Then you close up. We have come a long way in terms of trying to see the compression on imaging studies before surgery, because one of the problems we had for many years is that going in, we didn't know if we were going to find anything. And the rate of negative exploration was not low. But we've come a long way with MRI scans. This type of MRI is called an MRA. It shows the blood vessel. You can see that white stripe on the left of the image. Again, I'm losing my arrow here, so I can't show it to you. But you can see it goes along the nerve. Let's see if I can. Pardon me here. Trying to get my arrow back. Seems to be not going to happen. But anyway, the key here is, and the point is that the MRI scans are much, much better showing the vascular contact. And they've gotten good enough now that if I don't see it on an MRI, it ain't going to be there. So we really don't have any negative explorations anymore. And I typically, if I clearly don't see something on the preoperative special MRI sequences, I tell the patient probably not a good operation to have, because you'll probably walk away disappointed.
Doctor, quick question. Yes. Have you heard about the Fiesta MRI?
Yeah. I don't have a picture of the Fiesta. That's the other image. That's even better than this one. But yes, the Fiesta is the bee's knees. That's the one. It's a Fiesta is it's a trademark name. It's not really stands for anything. It's one company's name for this image, but
Siemens?
I think it might be Siemens.
Siemens, yeah.
But in any case, it is extremely sensitive to finding a blood vessel there. So if you don't see it on the Fiesta image, you can pretty much guarantee that it ain't going to be there.
Do you do at University of Michigan?
Yes. Yeah, I think most places do.
Oh.
Yeah, most places have it. It's now become standard of care.
Oh.
So if you go to a place and they are looking at your image, you can ask them if this is a Fiesta image, because that's the image to get, or image sequence to get. It will show it. This MRA tells you what's a blood vessel and what's not, but I agree with you that the Fiesta image is even nicer. Then there are the percutaneous procedures. I actually just did one today. These are old-timey procedures. They've been around for many decades, where a needle is put in the side of the cheek, just to the side of your lips, and taken all the way to the base of the skull. And through that needle, you place a probe, and you heat up the tip of the probe to coagulate a small area of the nerve, to cause some numbness. And that's the common theme for all the percutaneous procedures. They're all intentionally going to cause some numbness as the price for relief from pain. So this is the radiofrequency procedure. There's also glycerol and balloon compression, which use a similar approach. You can see in the middle image here kind of a schematic of how the surgeon does this. They have typically a finger in the mouth to kind of make sure the needle is going in the right direction. And the needle goes under X-ray guidance, and you can see on the rightmost image there is the X-ray of where the needle is going. In this particular case, there was an injection of radio-opaque material to kind of show us where the nerve is, make sure it's in the right place before the next step, which I think in this case was glycerol. But all the percutaneous procedures, be they balloon or radiofrequency or glycerol, they all use this needle approach. So
you do all three of those in Ann Arbor?
Mm-hmm. Yep, we do all of them.
You personally or other neuros?
Yes. No, I do most of them. I have a junior colleague who does them as well, Kevin Chen, and he's excellent. I know that because I trained him. So, but yeah, so yeah, this is the one thing about having a non-vascular neurosurgeon do the trigeminal neuralgia surgery is that we tend to choose from everything that's available rather than the only thing we know how to do. So that's the difference there. So I don't know if any members of the audience here have tried to get a glycerol injection in the last few years. It's been nearly impossible to get a glycerol injection. It used to be very easily obtained. We used to do them all the time. About, I would say, 5 years ago, they essentially took them away. They basically, the new FDA guidelines on sterilization, and I think that the whole USP, I can't remember, the United States Pharmaceutical standards, essentially made it impossible for most places to sterilize glycerol, just because it's so thick. Everybody who's ever seen glycerin, it's the same thing. It's incredibly viscous, and it's very hard to filter because it's so viscous. And ironically, because it's so cheap to make, that no company wanted to get into the market of making sterile glycerol because they couldn't make any money off of it. So it became really hard to obtain. We recently we're able to find a pharmacy in Kansas that is able to ship us sterile anhydrous glycerin to use. I don't know if I'm going to be using it very much even still now, because I've gotten so used to using the balloon compression, and I like it so much, which I actually hadn't done any until the glycerol was unavailable, because they have very similar indications. I was always doing glycerol until it was unavailable, and then I said, okay, I'll have to do the balloon. But ironically, then the balloon stopped being available too. This was a company called Cook. A company called Cook was really the only company that made the balloon. They made the whole machine that inflated the balloon and so on. And they were a small medical device company. They essentially, I don't know if they went out of business or they just decided to make a decision to stop making it. And so a lot of my colleagues, across town who used to use the balloon all the time, they just stopped doing the operation. What most of us who still do this operation do is we MacGyver it. There is a Fogarty balloon that you can use. I think these are images of the Fogarty balloon. That's very similar to the Cook balloon. And you can use a needle. You can see in the bottom right here, it's a pretty big needle compared to the needle that you saw before. Here, you see the other needle here? It's pretty thin. This is like a spear, but it goes in very much in the same location. And the balloon, which you see on the bottom left there, looks like a little, I don't know, like a submarine, like a pill. When you fully inflate it, when you're in the right spot, as you see in the bottom right corner, it looks like a pear. You see that? Mm-hmm. Right. So that pear shape means that balloon is being deformed by the place that it's in, and that place is what's called Meckel's cave, and that's where the trigeminal nerve lives. If you happen to not be in Meckel's cave or just to the side of it, you get a picture very much like you see in the middle panel. You notice it looks like a pill. So I just saw a patient at Metro about a month ago who had two balloons over a period of about 15 years. And the first balloon worked great, and the second balloon, not at all. And the first balloon gave her numbness, the second balloon, not at all. And the reason for that was that the first balloon was in the right spot. The second time, it happened not to be. And it's not always the surgeon's fault. Sometimes the catheter can penetrate the outside wall of where the nerve is and can inflate outside of that area without you being able to control it. But it's good to know if you end up having a balloon compression. It's a good question to ask your surgeon if they were satisfied with the shape of the balloon, because that tells you a lot about the chances of success. Because if they had a balloon shape like the one in the middle panel, it's not going to work. I can tell you because it's happened to me.
Can you redo it right then? I'm assuming.
What's that?
You could replace it right then, I'm assuming.
Well, you can try. It's not always possible. It's not always possible to get it once there is a hole in the wall of the Meckel's cave. The catheter can sometimes just seek it out every time you push it in. Okay. So you can try it and rescue it. I've been successful when that's happened about 70% of the time. But there's 30% of the time where I just couldn't do it.
Well, that whole fill it back in, and you can try again. And
yeah, exactly. You can try again another day, right?
Okay.
So anyway, I just wanted to mention that to the group, just because this is the procedure that has a lot of value, but there's a lot of art to it. And in fact, one of the people who taught me how to do this was Jeff Brown. yeah. So he went. He did his residency where I went to medical school at the University of Chicago, and learned from the person who perfected this, Sean Mullen. And so Jeff really, he used this as his calling card, the trigeminal balloon compression. He's probably the best there is at it, but it is very much an art, and you really have to depend on that pear shape before you have chances of success. All right. Now, the seesaw of decision making in all of these procedures, aside from microvascular, is that the more numbness you have, the better your chances of long-term success. But the more numbness you have, the more side effects of that numbness, complications of the numbness you can have. The less numbness you have, the less of the side effects and complication rate, but the higher the recurrence and the lower the chances of success. So there's always this balance. And in fact, like with radio frequency, for example, where the person who's having it done actually comes in and out of consciousness to help us in terms of directing where the tip of the needle is. John too, who really was the big champion of this, he used to spend hours doing these operations, would wake people up all the way to the point where he could test how much numbness they had. Then he would put them back under, and do more if he needed to do more. I have never been able to do that. I've often complained to him that he must have better anesthesiologists than I do. Because the patients where I practice, including today, for example, where I did this, I can barely get them to tell me where they feel the tingling and so on when we are changing the settings and so on. I will never be able to have them tell me how numb they are. The anesthetic makes you as a patient completely unreliable. So I tell people ahead of time, I say, you know what, first time we do this, I'm doing one lesion. And if it's not enough, I'm coming back again and we can do this again. So I much rather, and this is again, I'm giving you my talk here. This is how I practice.
Sure.
I don't, it's like they say, it's better to be in term when you're flying, it's better to be on the ground wishing you were in the sky than the other way around. You can always come back and fight it again, and I don't want to ever regret having done too much at the get-go, because the main problem of these procedures is intense numbness with pain, something known as anesthesia dolorosa, almost impossible to treat, and all you have then is regret. So I want to be able to sleep at night, so I don't do it that way. I don't try to be as fastidious as John too. I do one lesion. If it's not enough, down the line, I do two. Like this was a guy I did one lesion a few years ago. He came back, and he said, make me more numb. So I did two lesions. All right. I've got some. All right, look at this. Hold on, it's not responding to me. There we go. Here we go. So now I have to go through this again. So I'm going to go through the success rates in the literature of all these procedures. So you can take a look at the MVD, RF, glycerol, balloon, and gamma knife. We didn't talk about the gamma knife, mostly because we don't do the gamma knife at Michigan. We don't have a gamma knife. We have a linear accelerator, but the accuracy of a linear accelerator isn't quite good enough. The gamma knife is the only one that has a proven track record in this space. But you can see the success rates are extremely high for all the procedures immediately afterwards, anywhere from 91 to 98%, except for the gamma knife, where you really feel no different walking away from that machine. And that has to do with the biology of radiation. Typically, people start feeling benefit from Gamma Knife about a week. Sometimes I've heard people say a few days afterwards, but almost never right away. It's just the biology of radiation just doesn't let it go that way. But you will notice that there is a recidivism rate. All of these procedures have a recidivism rate. This is the nature of the beast. Trigeminal neuralgia is a beast, and it almost invariably will come back at some point. The success rates are highest with MVD over longest term, but they're about the same for radiofrequency, if you want to really be honest about it. So both the RF and MVD have very high success rates comparatively in the long term. Things like balloons and glycerol and Gamma Knife, they have a higher recidivism rate in the medium and long term. So you're more likely to need a second or third procedure with those. On the other hand, in MVD is, as some of the people who are on this call know, that's no picnic. That's an operation that requires, a hospital stay. It requires a recovery. It has complication rates, spinal fluid leak, chemical meningitis, all kinds of things that you don't have to contend with the other ones that are mostly just outpatient procedures. All right. So, what are the risks? Where we talked a little bit about microvascular. There's, it's a big operation. You can have hearing loss. You can have facial paralysis. Although most of the time now, people will get monitored for both when they're having this, and I think the rates of facial paralysis and hearing loss are extremely low with that. Spinal fluid leak we talked about, meningitis we talked about. So that's not a picnic. Radiofrequency, the main issue is numbness. And numbness can cause all kinds of other things related, the long sort of continuous burning and tingling pain, or numbness in the eye, which is one of the reasons why I don't do radiofrequency for pain that's involving the forehead and the cheek. So I don't want to make the eye numb at all. Glycerol has the highest recurrence rates. It also has some numbness. Balloon is better than glycerol, I think. Again, this is a reason why, this is my own bias. I think that the balloon's more predictable. And then the Gamma Knife it's got a shorter track record. It's not been around quite as long as these other procedures. And there are radiation risks, of course. But it is a good operation, I think, for some. So, what are the advantages for microvascular decompression? Well, we're not going to make anybody intentionally numb. We do need a vascular compression there for it to be successful, and it's also the highest risk procedure. But it does have the best long-term track record. The RF procedure, you don't really need vascular compression for it to work. You do get facial numbness. It's one of the downsides of all of these. And of all the lesions, I think it does have the best track record long-term. It does require a significant amount of experience on the part of the surgeon. That's why John too just kept getting better and better as he got older, because he had so many years of experience. Glycerol, again, you don't need vascular compression. It does have the highest recidivism rate, but it's also the least numbing. So the classic scenarios, and this is kind of how I think about trigeminal, if you had somebody who's young, who has pain involving, the forehead, that's V1, and you take into account the fact that patient's going to have low surgical risks, and we're looking at a very long lens for that person's life. He or she is 35 years old, and if hopefully have a good 60 or more years ahead of them. So you want to look at the long term. And so that's why we would typically choose a microvascular decompression for somebody like that. A 79-year-old with pain that's kind of around the mouth, cheek, and chin, you got to think about their medical health and the risk of surgery. They may or may not be on blood thinners at that age. That's also a consideration. And again, personal preference on the part of the surgeon plays a big role. So if I see somebody who's 79 who is in excellent health, I would still consider a microvascular decompression. But if they have some heart issues, some lung issues, or kidney issues, or whatever, I probably will tilt over towards one of the lesioning procedures. If they're on blood thinners, I might not even do that. I might recommend a Gamma Knife because that is a procedure that doesn't require you to come off blood thinners. Here's somebody who's 70 with pain around their eye. You know, you worry about eye numbness in somebody like this, and their health status and so on. So the two procedures I would consider for somebody like this are microvascular decompression or a balloon compression. So the balloon compression is not terribly numbing and it's safe to do with your pain is near the eye. You know, it's definitely lower risk than a microvascular decompression. But if this person is 7 years old, is in, you know, fantastic health, I don't see any reason to deny them a microvascular. So here's a 60-year-old with pain around their cheek who's had a radiofrequency 5 years ago. So what do you do with somebody like that? Well, you have to ask them how did the last operation go? Did you get a good response, or was it a complete fail? How long did it last? Did you get numbness? Was there enough numbness? Did numbness go away? Did that when the pain came back? So a lot of the answers that the patient provides me tells me whether it's worth going back to the well to do another radiofrequency or whether we should, you know, go to something else. Here's a difficult one, a 40-year-old with trigeminal who has multiple sclerosis. So this is young, right? But they also have a condition that predisposes you to recurrences and is probably not as good a long-term track record in any procedure that we do compared to somebody who just has normal, regular trigeminal neuralgia. You want to know how debilitated they are from their multiple sclerosis. Is it just this, or are they in a wheelchair and having other issues? So the health status is very important. But you also want to look at long-term outcomes here because they're 40. So this is where different people might reach different conclusions. You know, we all look into the crystal ball and see different things. So if I see a 40-year-old with multiple sclerosis and they look healthy otherwise, and they have a blood vessel on their MRI, I probably will tell them, listen, it's not necessarily going to have as good an outcome long-term as if you didn't have MS, but you have a good long life ahead of you. I don't want you to necessarily have numbness for the rest of it. So let's try a microvascular decompression. So that's how I personally would look at that. But another surgeon might look at it differently. So here's a 52-year-old who's on Coumadin for a heart valve. Well, this is a sticky wicket here. I don't think that I would want to have a needle in my head or a surgeon in my head, and if I had to be on Coumadin for an artificial heart valve, because I know that if I came off Coumadin, then I'm at a higher risk of stroke. So maybe this is a good candidate to be given a Gamma Knife. So we would have to ask, what kind of valve is it? Is it a mechanical valve? Is it a tissue valve? Because those have vastly different risks of stroke off of Coumadin, and those all weigh into how we personally decide to move forward. So I might have a couple more. Here's a patient with a pacemaker, a 45-year-old with pain that you'd normally advise a microvascular decompression. And I think in this case, you might still do that. You might still give them a microvascular decompression even with an implanted pacemaker. All right. So there's a decision tree that I have in my head. Is it trigeminal neuralgia? That's the first and most important question. It's how we started our talk. Because remember, this is a 10-to-1 or 9-to-1 odds that it isn't. But if it is, then we go on to the next. But if it isn't trigeminal neuralgia, if it's a different facial pain, if it's what they call SUNCT or trigeminal autonomic encephalopathy, or some of these other pain, atypical facial pain, things of that nature. Lots of patients have that. Lots of people have that. But I wouldn't offer them this surgery, not because I don't like them, but because I don't want to have them disappointed with the outcomes. But if it is trigeminal neuralgia, the next question is how's the patient's health otherwise? If the patient in good health, or are they not? If they're not in good health, the question is it involving their eye? Now, for me, that's an important nexus point, because if it involves the eye, I don't want to make it too numb because of the issue of what's called exposure keratitis. You need to be able to feel if you have a speck of dust or an eyelash or something in your eye, because if you can't feel that at all, your eye is at risk and you can lose your eye. So, I'm not game for that. So if it isn't involving the eye, then they can have the gamut of lesioning procedures, RF, glycerol, balloon, gamma knife. But if it's involving the eye, the balloon is really my go-to. Glycerol also is a good one, and the gamma knife again is another option. If they are in good health, again, I go to the involvement of the eye. If it isn't involving the eye, they really have the full gamut, right? MVD down. If it does involve the eye, I usually take radio frequency off the table. So this is kind of how I approach my decision making with trigeminal neuralgia patients. And I'd be happy, Tim, by the way, to make my slides available. Well, I guess it's going to be a YouTube talk anyway, but if members are interested, I'm happy to share them.
Yeah, great.
All right. So common questions. Am I too old? This has been looked at with a number of series that looked at patients in their 70s and even in their 80s, who are having microvascular decompressions and looking at outcomes. The answer is that chronological age is never a contraindication for microvascular decompression. Practically speaking, however, as we get older, our bodies don't get better. And so, like my dad always said, old age has nothing to recommend for itself. So basically, if the heart or the kidneys or, some of your other systems aren't working as well, then yes, age does factor in, but the strict chronological age isn't by itself a contraindication. And another common question is, what about burning pain? We talk a lot about trigeminal neuralgia as this classic, lancinating, electrical jolting pain. A lot of people with trigeminal neuralgia will also tell you that over time they've developed this more constant burning pain now that they've termed, trigeminal neuralgia type 2. So, what to do about that? The answer, is difficult here, because while that's still probably trigeminal neuralgia, these procedures do not work as well for it. So, in fact, some of them make it worse, like the lesioning procedures can make burning pain worse. The thought about burning pain is that is a sequela of having continuous damage to the trigeminal nerve over the years, and it develops this burning pain like if you have diabetes and you have burning pain in your feet, that that diabetic neuropathy kind of thing, that this is a neuropathy type pain. It's no longer strictly trigeminal neuralgia, it's trigeminal neuropathy. And these procedures cannot recreate the nerve as a healthy nerve. So you go in there, even if you see a vessel and do a microvascular decompression, you decompress it, you did a great job, that nerve is still sick. And that sickness of the nerve is still going to likely result in burning pain. So burning pain is a real problem for surgery. It doesn't tend to work.
Doctor, is that, we heard at a conference in '08, excuse me, that the earlier you do, I think it was a study out of Germany, the earlier you do the procedure, the better, because you might result in something like this. And I know all the neuros here recommend meds first, but on the other hand, then if you say, well, if I wait a while, I end up with something that the procedure can't fix.
Yeah, it's an unanswered question. I've had a number of conversations with Kim Burchell about this, and Kim is the one who kind of put his name to this nomenclature of type 1, type 2, and believes in the continuum of type 1 to type 2 developing over time, precisely for the reason that you mentioned. And he also posed the question, should we be offering surgery earlier? I don't know that we're there yet, honestly. This is one of those things that is still an unanswered question. The procedure is still a big enough procedure with enough risk that you'd be hard pressed to put somebody who just started having trigeminal neuralgia, on it, because I think that the risk benefit scale still tilted too far towards the risk. However, I'm guessing that there is probably a sweet spot. We had a department administrator in our hospital in Michigan who suffered with trigeminal neuralgia for a number of years, but it was always just this lancinating, came and went, disappeared for a year, came back. And we had this discussion, because I told him it's possible that over the time it will eventually, develop into this constant burning kind of undertone. And eventually we did, offer him surgery because he was just too nervous about that. He didn't want to have it in a way that didn't go away. So I do think there's merit in there, but I don't think it's like right when you start, right?
Right away.
I think that there's enough people out there who will have maybe 1 or 2 or 3 attacks over a period of a few years, recurrence remissions, and then they never hear from it again. That there's enough of that going around that you wouldn't want to pull the trigger so early. But the study hasn't yet been done, to my knowledge, of randomizing somebody that at some point 5 years out from their first attack to having a microvascular decompression, even if they're not having pain.
Yeah.
See? So it's a great question. I don't have the answer, unfortunately. A common question I get is, how many surgeries can somebody have? It depends on the kind of surgery. With the percutaneous needle procedures, you can have an infinite number of procedures. The problem isn't so much how many can you have, it's how many are useful. You probably get to the point, the most I've ever done on anybody was 6. But at that point, if it's not giving people relief for a long enough period, and you keep going back to it, I think you're not being intellectually honest. You have to at some point say, okay, this isn't working anymore. Let's look at something else. So I would say you can have as many as are useful. Let's put it that way for the percutaneous ones.
Yeah.
Now, microvascular decompression is a little bit of a different issue because going back in a second or even the third time on the same side is fraught with some problems. The scarring that occurs as a result of that operation makes subsequent surgeries more difficult and more risky for hearing, for facial paralysis, and the like. So it's at that. I've done a few redo microvascular decompressions, and you know they went well, but I wouldn't jump into it. I usually with patients who have recurrences after microvascular decompression, I usually would advise on another Fiesta MRI scan, because the Fiesta MRI actually visualizes the Teflon pad pretty well, and you can tell whether or not it's sitting in where you put it, and it kind of tells you whether or not going back in is going to be of any use to the patient. So the answer to how many surgeries can you have is you can have as many as are useful.
Do you see the Teflon moving in a lot of cases?
I've only seen it move once, and it was a case of Dr. Chandler's. You know, if anybody ever heard it, he's retired since. He was one of our surgeons here, and he did a surgery on a woman with trigeminal neuralgia, and she, a week after surgery, decided that she wanted to jump on her trampoline, and that's the only time I've seen it move. So the answer is it's very difficult for these things to move once you put them in, especially, I would say, more than a month out, because by then the scar has formed enough around the Teflon that it ain't moving. I don't know if anybody has ever put their hands on a piece of Teflon. It's not quite as rough as Brillo, but it's rough. So it's not slippery. You know, we tend to think of Teflon as being really slippery. This is not a Teflon sheet or Teflon tape blend. And some people here do construction and, you know, wind that around threads and stuff, and that's very slippery. The Teflon pad, it's actually felt. So these are little fibrils that are mashed together. Kind of looks like a Brillo pad, and so once you put it in, it ain't coming out. And you know, again, the only time I've ever seen it move. Now, what I have seen at least once was somebody who had the procedure done in like Central America, and came back and never relieved her pain, and all she came out with was a paralyzed face and hearing loss. And so I had a feeling that the guy put the Teflon on the wrong nerve, and sure enough, there was a big wad of Teflon on the facial nerve, and the trigeminal nerve was pristine. So it, you know, it can happen. I mean, I haven't seen it happen in the U.S., but it can happen.
I thought Dr. Casey said a while back that he wasn't using Teflon anymore. Lynn might remember better than I do. Anyway, I don't know if there's...
So some people don't use Teflon. There's another compound that people used to use called Ivalon, which was another matrix. Okay. I don't even know if we have that anymore. And some people just don't like Teflon because they feel that it compresses the nerve as well, and they prefer, you know, doing this complicated sling on the nerve or the vessel to try to keep them apart naturally. I personally have not tried that. I don't have the temerity to do that. This is a very tiny little place, and I think trying to do something fancy like that, in my mind, is a little too fancy.
Yeah.
So,
thank you.
All right. So let me just go to the next. Oh, more questions. I guess I'm done with my formal talk. I didn't want to have it go too long because I wanted to make sure I had time to answer questions. I know we just got started with the questions.
Okay, Katie has a great question. Katie, do you want to ask Dr. Sagher your question?
You have to unmute, Katie.
Yeah, I'm going to
Okay,
stop sharing so we
sorry.
can see each other.
Here she
more.
comes.
Yeah, that's what I had to do too. So my question is, I have an MRI that indicates that I have a vessel mildly contacting the undersurface of the cranial nerve without displacing or distorting it.
Yeah.
I'm curious if this is the kind of situation in which you might not feel MVD would be clearly successful, since it says there's no compression.
So I will go back to my first slide and say, is this trigeminal neuralgia? I think if it is, and there's a vessel in the right spot. Now the right spot means that it's not way out from where the nerve comes from the brainstem. So the nerve starts in the brainstem and moves out from there towards the face. So the farther out towards the face it is, and it's only about a distance of less than a centimeter, so it's not very long. The farther out it is, the less likely that it's causal. If it's tucked into the armpit of the nerve, even if the MRI doesn't suggest that it's compressive, I would still do it, especially somebody young like you. If it's classic trigeminal neuralgia, somebody who's in good health, and there's a vessel in the right spot, I think I would do it. Not everybody's going to have, the real compressive looking vessel. But as I always say, in poker, you don't have to have a royal flush to win the hand. So a full house will do it too.
That's helpful. It says, the MRI says the undersurface cisternal portion of the cranial nerve bilaterally. I'm not quite sure if that gives you enough information to know.
Well, we talked also about the fact that 40% of people have it on the other side as well. The MRI itself isn't so much a diagnostic tool as a planning tool. Mm-hmm. And so again, it goes back to you and your experiences with the pain. And then the MRI helpful in terms of knowing what to expect. And if the vessel is fairly distal, out away from the brainstem, I would say probably I would shy away from surgery. But if it's close in and there's clearly a vessel there, I would still look at that. Yeah.
And do you sense that there's a different type? Should I be doing the MRA before moving forward with deciding on MVD?
I'm embarrassed because I was going to put a Fiesta sequence there instead of the MRA, and I forgot. But Tim pointed that out. The Fiesta is much better than the MRA. I usually do both. In fact, when we do the what's called the nerve compression protocol MRI scan, it has both those things, the Fiesta and the MRA. But if you had to choose between the two, it's the Fiesta that is a better planning tool.
Okay, thank you very much.
Dr. Sagher,
there's other questions here. I can open the chat here too.
Yeah, Vanessa has a question for you, Dr. Sagher. Vanessa,
okay, please.
Unmute yourself, please.
Okay, hello.
Hello.
I've had a TN for 12 years, and most of the 12 years they had me in psych saying that I was crazy. See, in November, and there was compression, and I'm still in pain. So I don't know what else to do. I don't have any support at home, so I don't know what to ask the doctor now or what, because the pain is still coming over on this side, and now it's on the right side. The dentist said it's on the right side. So I don't know what to ask. I don't know what to do. I'm in pain every day, and I'm at work.
Yeah. Well, pain that's on both sides of the face is always a red flag for a something that's masquerading as trigeminal neuralgia. There's plenty of pain conditions that can do that masquerading pain. I wish there were a blood test or some other more objective way to diagnose TN, but unfortunately it's purely clinical. And because it is a purely, clinical based on your symptoms, there's the chances are not low that there are going to be some people, maybe you are one of them, who have the pain without having the trigeminal neuralgia. It's facial pain, but as we mentioned, 90% of facial pain ain't trigeminal neuralgia. The fact that you're having pain on both sides is a real concern.
Okay.
I operated not too long ago on a woman who had trigeminal sounding pain, and on the one side, and on the morning of surgery, told me that she was starting to have pain on the other side. And by then, I was facing a decision: do I cancel surgery, or do I just go ahead and do it? And I just went ahead and did it because I felt that we had come too far down the path.
Right.
I did the operation. She got no better. She got no better. And we found a vessel. Again, finding the vessel is not the issue. Doing the right thing to the vessel is not the issue. The issue is I operated on a patient I probably shouldn't have. And so it's possible. And again, it's no fault of yours or of the surgeons. It's just sometimes difficult to sort out trigeminal neuralgia from one of its cousins. I think let's put it this way: if your surgeon felt that they got a good look at the nerve and they saw the vessel and they were able to decompress it and looked fine, and you never got better, that's a sign that vessel is probably not a culprit.
Okay.
So I wouldn't do that. I wouldn't re-explore that, and I wouldn't do that operation on the other side either.
Okay.
So it's one of the big problems with trigeminal neuralgia surgery. So much of facial pain that is out there that people have, that people suffer with, isn't surgically remediable with these operations. The best thing we can do as surgeons is not to put them through all the trauma and the healing and all the because you went through a microvascular decompression. You can tell me it isn't easy.
No, it's not.
It's not easy.
Although we have another case like Nadine, and she had an MBD on one side and it reoccurred. She had a very successful MBD on the second side and has been pain-free for 20 some years, right, Nadine?
There she is.
Can you hear me?
Yes.
No, I only had one MBD on one side, and it involved the lower jaw, and I never had another MBD or any other procedures, and that was 18 years ago, and I've never had a reoccurrence.
Oh,
I think it was me, Lynn. It was me that has had two on one side.
Okay.
Yeah, I had it 18 years ago, and I've been very fortunate. I've never had another reoccurrence.
Okay, I messed that one up. Thank you.
No, that's fine.
Okay.
Yeah, Maria, yeah, you're the girl.
I'm the girl.
Yeah.
So it's somebody in the chat, and it was Marcia, I think, who had a great question. Why does the success rate of the microvascular decompression decline after 5 years? I wish I knew that answer. And it's what we used to call the $64,000 question, right? Because if the vessel were causing the pain, and you've decompressed the vessel, it's away from the nerve. Why 5 years down the line does the pain in some people come back, or 10 years? I mean, why? I have posed that question myself. It is totally unclear as to why that should happen. I mean, I can understand why in some people it just doesn't work. Maybe the damage is too much in the nerve. I mean, pain comes from the nerve; it doesn't come from the vessel. So maybe in a lot of people who don't have success with these operations, it's just because the nerve is too sick. But why, after a seemingly successful operation, you're just going about your merry way, and all of a sudden it comes back? I've posed that question to Kim Birchall. He has no answer either. So if somebody can answer that question, I am, I'd be all ears, because it's just a difficult thing to put together. It's clearly related to that vessel in some way. I mean, maybe not quite as zealous about things as Peter Janetta was, in terms of believing that the vessels were causing everything, but the phenomenon of having somebody in misery, with repeated attacks, going into the operating room and never, feeling that pain again when waking up, is pretty convincing and compelling, to say, well, it's the vessel. But why does it come back in some people? And it does, in Janetta's own series.
Yeah.
Yeah. I wish I knew.
Okay, thanks.
That's a great question.
I was hoping for a more definitive answer.
Oh, yeah. Yeah.
That's a tough one.
Yeah, I'm going to have to ask somebody up there.
I get it.
Darn
Well, thanks,
human.
because I've been wondering for a while, because it's a tough decision to make if you go ahead with one, and
Yeah. Well, I mean, let's put it this way: of all the things that we have in our armamentarium of fighting this awful disease, the microvascular decompression, I think, is the best one in terms of its its longevity, and the trade-offs. I think if you're healthy, otherwise, it really has the best bang for the buck, but it still ain't 100%. There's nowhere close. No procedure has 100%.
Okay, thanks.
Aaron has a question here. Let me read it here. If the TN shocks are not classically triggered, maybe spontaneous, would an MVD be considered? If it's just spontaneous? Noise, conversation, listening, concentration. Right. But so the issue of triggered pain versus spontaneous pain, almost everybody with trigeminal neuralgia has both. So that I don't know. Sometimes we try to connect environmental phenomena with what we feel in a way that may not necessarily hold water. Like, certainly stress in general will trigger multiple types of pain, no matter what the cause is. And if you are just somebody who's stressed by, a lot of noise around you, it could cause that. But I don't think noise in itself will trigger trigeminal neuralgia. I don't think that there's any direct link between noise and trigeminal neuralgia. It could be just the spontaneous attacks that are basically more common and just come more frequently when you're stressed.
Okay. Yeah. Thank you.
He has a motor cortex. Would noise have anything to do with the motor cortex causing pain?
So are you talking about the motor cortex stimulator?
Yeah, Aaron
Right.
has.
Yeah, I have a motor cortex stimulator as well. I shut off the video because I'm starting to.
Yeah, I saw that you're wincing.
Yeah.
The motor cortex stimulator is an interesting has an interesting history. I personally have lost faith in that procedure. I was relatively enthusiastic about it some years ago, just given some of the early data from Japan. But the only and I've put in a few in my patients. Only thing I was reliably able to do is cause seizures. The motor cortex stimulators reliably, they don't cause epilepsy. They just you can stimulate seizures just because you're stimulating the motor cortex. And that's the only thing I was able to reliably do with it. I know Jeff Brown did a few, Probably did more than I did.
He
What's
did
that?
errands. He did errands.
Yeah.
Yeah, Dr. Brown, Jeffrey Brown did mine, and it works wonderfully. He's got the settings and the placement. Placement, of course, is key.
Right.
And then also the settings. I have a few programs and settings that I've been able to develop over the years that work very well. And when one setting stops giving me relief, then then another setting will give me relief. Just the plasticity effect,
right?
Just changing it helps the constant pain, the relief for that. But I've since developed the classical shocks, but they're not triggered with touch or wind or anything like that. So I'm one of these patients that I don't fall into any of the categories.
Right.
So
Yeah, you may be one of the 90%ers.
Yeah. I'm still looking. So thank you, doctor.
Yeah, I wish the best for you. And again, Jeff probably has more experience with these than anybody else in the country. I just was not able to reliably make them work for my patients, so I kind of gave them up. And a lot of my colleagues around the country have similar experiences.
All right, thank you.
They're just a very challenging treatment. Yes. Somebody, I think
Melody has a question.
Melody's holding up her hand.
Yes, doctor, I know you aren't really here for those 90% facial pain people that are, probably.
I'm here for everybody.
Oh, thank you. We appreciate that. I know I don't have probably the classic TN because it's never been shooting, electrical, or stabbing. It's the aching, burning. And I guess my question is, I know none of these surgeries would probably work in my situation, though I haven't been, Fiesta MRI'd or whatever, but would this probably fall into like a trigeminal neuropathy because it's a sick nerve situation?
Well, so trigeminal neuropathy itself is also a defined condition. It doesn't comprise the majority of that 90% either. So there are people who have clearly trigeminal neuropathy. These are people who, may have had like a tumor in their trigeminal nerve, or may have been in a car wreck where the trigeminal nerve was injured, from a facial fracture. Those people, you clearly know that have trigeminal or cancer, God forbid, of the head and neck where it affects the nerve. Those people have trigeminal neuropathy, pretty clearly. But even they don't comprise the majority of that 90%. Unfortunately, if you look at the international classification of headaches, the Headache Society, it's mind-bogglingly long, and I can't even keep it straight. It's so granular.
It's immense.
It's immense. And I think, it doesn't do much good to try to memorize it. It's just good to have some humility when treating a condition that is this challenging and this varied. You never want to squeeze people into a certain box because it's convenient to do so. And unfortunately, I see that sometimes in my practice where people, somebody comes to them with facial pain, trigeminal neuralgia. It's because that's the box they have.
Right.
And I spend a lot of time in the office talking to these patients, and after kind of understanding them a little bit, to try to explain to them why they may not have that. And it's a difficult thing. I mean, because they still have facial pain, they still suffer horribly. But I'm just not in a place or in a position to offer them, anything by my hand to help them.
Right.
Oftentimes I will offer, Tim's number to them, because I think, people like you and groups like this are the community of this is just so helpful, and to people like that. So, I can imagine that, as I was writing this talk, I said, this is probably a talk that applies to very few people in a group like this, because you guys are not in this group because you had trigeminal neuralgia, had it successfully treated and never heard from it again. You're people who are committed, interested, looking for answers, want ideas, and may not have trigeminal neuralgia, or may have it in a way that a surgeon really can't necessarily help you in a traditional way. Anyway, my missive was to talk about trigeminal neuralgia, increase understanding of that, but I understand, somebody before the conversation started, we're talking about ear pain. And where I started to mention that, like, the ear is, if you think the face is complicated, the ear puts it to shame.
It's even more painful. I can't believe it's even more painful than the shocks of your face. It's like it's a skewer right into your eardrum.
Right. So there's that, and of course the nerves that innervate the ear. There are at least 6 of them. Depending on whether you're talking about the outside of the ear or the inside of the ear, and even so the trigeminal does a little bit, but then there's the geniculate, and then there's a glossopharyngeal, and then there are the cervical nerve roots that come from your neck that innervate some of the ear. So the ear is really, really, really difficult to have a good understanding when you have pain. So I've tried to help people with ear pain. I know the otolaryngologists have to deal with that condition a lot more than I do, but whether it's some geniculate neuralgia, glossopharyngeal neuralgia, or sometimes it's something affecting the nerves that are in the skin that go to the earlobe. So it's just a very difficult and challenging area of the body to sort out.
Yeah, it is. Katie had a really nice comment. Katie, would you like to read that to Dr. Sagher?
What?
I'm just feeling a lot of compassion that you have for those suffering with this condition. I would love to understand what drew you to study and treat patients with trigeminal neuralgia.
Oh, geez. Well, I'll start by saying I love all my patients. Doesn't matter what they have. And if you don't love your patients, you shouldn't be doing medicine. So there's that. But I guess, I don't have any family members that have it. I know that would be a pretty good draw, but I don't.
Adopt us.
That's true. I have you as my family. That's true. Thank you for that. I appreciate that. Yeah, thank you. Well, I don't know how I ended up doing so much of it. I do tend to it grabs at my heartstrings when I see people come to my office, much in the way of when Aaron was on the camera, to see the suffering that's in the unpredictability, and just the out of nowhere kind of thing where they basically will talk to you and all of a sudden have to stop and hold their face and wince, and it just makes my heart hurt.
Yeah.
So
empathy. I think empathy, Katie, is probably the one word that was coming through to me.
Yeah.
Compassion. Yeah, compassion.
Empathy.
You're fabulous, Dr. Sagher. We so appreciate your time.
Yeah,
well, you don't have to thank me. I'll put my mom on. You can thank her for that.
Oh, yeah. It's here for moms.
That's great.
Yes, you.
We have more questions. I don't have the chat feature. Lynn, is there somebody else that has a question?
think that's it, isn't it right, honey?
Okay.
Any other
Well,
questions?
I'll let you guys talk. It was a pleasure seeing you guys again.
Thank you so
Tiff,
much.
and
We
Bobby.
really
Thank you, doctor.
Thank you.
Thank you so
Thank you
much.
so much.
You're
All right,
fabulous.
take care. Hopefully next
Thank
time
you
in
very
person.
much.
Yeah, you're fabulous.
Thank you.
Thank you.
Good night.
Very
All right.
informative.
All right, take care. Take care, guys.
Thank you so much.
Bye-bye.
Wow, he was excellent.
Maria, thank Maria for bringing him to us.
Oh, yeah, I didn't know anything about him, which is why I thought it was important, because as far as I know, it's Dr. Casey. Did he ever receive a liver?
On the 28th, he's supposed to get it.
Thank goodness.
Oh, great.
Oh, good.
Yeah. Yeah.
But so I've been bouncing around, like kind of interviewing
Right. Sure.
neurosurgeons, because I don't
Sure.
really know who I would be comfortable with should the need arise.
Marcia, do you have a question?
Yes, no, I just want to contribute for a second and then I have to go because I'm leaving to go out of town tomorrow.
Pete, you have to turn back on.
Can you hear me?
On, Pete. Okay. Sorry.
Okay,
Mike.
I wanted to
sorry
just
about
tell
that.
you that I actually was referred to Dr. Sagher, I don't know, I want to say maybe 8 months ago. And it took a while to get in. And I really, instead of seeing him, because I wanted to be seen sooner, I saw the nurse practitioner he works with in 2 video chats to determine, whether I'm a good candidate for an MVD.
Sure.
And I have to say, even though I just met him really for the first time today, that she was wonderful. I feel like I'm in good care. I'm not going to go ahead with anything right now, but I'm kind of in talks to see when I might, if I really need to. But the point is, I really felt a lot of warmth, but also a lot of knowledge. And I didn't really know what to expect. And so today was really, really helpful for me to meet the doctor who would likely do the surgery or any of those procedures if and when I elect them. So
Right.
it was really helpful for me. And even though he's kind of hard to get into, you can get into Donna, I can't think, Rossoni, I'm terrible with names, but she had consulted with him and she, continues to consult with him. And she educated my husband and me on, what my options are and what they recommend. And
Nice.
I've continued to email with her on the University of Michigan platform. And I always get a response within a day. And if she's out of town, someone else tells me she's going to be back in a week and then she'll get back to you. So very, very responsive. And I have to get going, but since I've had some personal interaction with them, I just thought you would want to know that thumbs up so far.
Yep.
Great to know. Great
And
to know.
also, I wanted to thank you all because, I found you guys a long time ago and I could never meet in person because I'm in East Lansing and, I never really felt like coming to Detroit. Not that I don't come to Detroit, but at night and all. And I really can't come to all the Zooms, but I really like it. I'm really happy. And
Good.
Tim, the YouTubes are great. And I've learned a lot. My husband has learned a lot. No matter how I suffer from time to time, it's a great comfort to have support and all your knowledge. So I just.
Do you have her last name, Pete? Do we have Marcia's last name?
Horan.
Oh, yeah. Okay.
Okay.
Yeah.
Right. Thank you so much, Marcia.
Okay, I'm
Thanks,
going to head
Marcia.
out, but thank you all. Take care.
Have fun out of town.
Bye.
Thank
Stay
Pete
safe.
for the YouTube, guys.
Okay.
Pete's been
Bye-bye.
putting on
Here.
YouTube.
And Pete, I apologize.
Don't worry.
He's used to sassy, Maria. He's used to
I was going to say the same thing. That guy was amazing.
Yeah, he
Yes, so I don't want to edit again. Yes.
yes, he was great.
There'll be a couple of minutes missing on the final product. No problem.
Yeah, it's really not-
I'm sorry, you guys.
That's that quick.
That's funny. Does anybody else have any comments or questions or?
I just want to ditto everything that.
I'm going to sign off for now. So we'll talk to you at a later time.
Bye.
Everybody take care.
Take
care.
Take
Bye,
care.
Nadine.
Yeah, it's not.
Good trip.
Bye. See you, Jen.
You
I just wanted to ditto what Marcia said because I feel so grateful for this group and all of the connections you have helped make, Tim and Lynn. It's been just an incredible lifeline this last 2 months. So
Yeah, I
continue.
want to say that too.
Thank
you
you.
You're
know.
part of us, Katie. We're so happy that you found us and that you feel supported, because it's a rough road. It's
Thank
just
you.
rough.
Can be.
Yeah.
Yeah.
There's
I think it's a rough road with facial pain, period, really,
Yeah.
whether it's TN or not the classic TN, it's just a rough road with facial pain.
It is.
There's
And
a-
I want to say I appreciate you, Lynn, and Tim, especially because I talk to you so much. You guys are great.
Oh,
Thank you.
Sorry, you
I
guys.
see a Rita Ricardo, but it looks like a gentleman. Are you new with us?
Get unmute.
You gotta unmute.
I think it's frozen. No.
No, here it comes.
Goes.
Yeah, I'm new. My name is Tony.
Hi,
Hi,
Tony.
Tony.
I'm from Windsor.
Oh, cool.
Awesome.
Are
Glad to
you
have you with us.
General?
Yes, sir. 2
What's
years
your-
now.
What's your last name, Tony?
Same last name, Ricardo.
Oh, it is. Oh, got it.
This is my wife's computer.
Okay.
Well, we had to change Tim. His name was Donna earlier in the meeting.
You're new to the group. Can we help you at all?
Well, the speaker tonight was awesome.
Yeah.
And Maria, thank you if that was you that got him. The speaker was awesome. I'm going through a lot right now. I'm on some heavy medication. I'm 2 years in on this dreaded illness. As I'm speaking right now, I can feel my
Yeah.
my jaw acting up.
Can you send me, Tony, your email address?
Sure.
Mine is, if you look at the letter, Lynn and my address is on the bottom of the letter. Just send me your email address. Maybe you're on the list. I don't know. Did you send him the invite, Lynn?
Yeah, I think we talked, didn't we, Tony?
Gary Goodman.
Oh, you
Gary.
found out from Gary? Oh, we love Gary.
Me and Gary belong to a group, and I heard him talking about his pain.
Oh,
3
Gary's
years ago.
amazing.
He's amazing.
He's such a cool dude.
Yes.
Yeah.
Maybe we can help you offline, Tony. Email me and tag dude at webtv.net and we'll talk offline.
Say that again.
I'm posting it right now.
Okay.
Thanks, Pete. Vanessa's gone. I want to talk to Doc. She's in LA.
Amy had a question here.
Who?
Amy?
Okay.
Just saying hi, no question.
Okay.
Hi, I got
Hi,
it.
Amy.
I'm sorry. I guess you're all ready to go, but
You have her last name, Pete?
I do not. We just do first names. Who's last?
For our attendance list, Amy?
I do not. I don't know if you want to give her last name.
and what's it for? I'm sorry.
We just send it in.
You don't have to cut your list.
Yeah.
If you want to be you got the invite, so you must be on the list.
I'm on the list. So
Okay.
should I give you want my name? I mean, they have my facial pain has it.
Yeah, just
Whatever I don't care.
What's your last name, Amy?
Ryer, Reyer.
Okay, got it. I probably have it in my system, but
Yeah, because I get your emails.
getting to it's a little difficult. I'm not the best with the PC or the system. Thank God we've got Peter.
Where is he?
let him out of the basement after the meeting.
There you are. Did you have, I know there was going to be a doctor tonight, I guess that happened already?
Uh-huh.
Yeah, it'll be posted on YouTube, and it was a great presentation, and we'll try to get the slides. I think we should capture those because those those are fantastic material.
I took pictures of some, but I'll ask him for them.
Yeah, ask them for the slides.
Great. Yeah, no, he was excellent. Yeah, we usually start at 6, Amy.
I know. Are you New York time? I don't know if you're in Michigan, so is it the same time?
Same time.
Yeah, I think right now we are.
I think so.
Yeah.
I was out driving. I couldn't. But in my head all day, I wanted to be here.
You'll get to see the recording.
It's on YouTube, so it'll be there, right?
Yep, absolutely.
By date? Do I find it by date or?
No.
Yeah, how do we find it? How do we find the particular one?
Look
Can you
at
go to? Go ahead.
Go to the YouTube channel. This tag dude on YouTube, and
put in Tim Guth.
that's right. Tim Guth.
Facial
Right.
Pain started that for me about 10 years ago.
Okay.
You just look at the letter, Maria. It explains all that there.
Okay.
Everything's going okay, Roseanne? You look solemn. What's up?
No, just tired from a long day of work. He's doing okay though. He had the balloon, as we all know, and it's about a little, just almost 2 months, a little short of 2 months. He's doing okay. He's starting to feel some pressure here, he said, but he hasn't really tapered off all his meds. He's deathly afraid. So he's on 4 different meds. He's off now the Dilantin, which was the last med added by Dr. Brown, because he was in such severe pain. He's still on 3. He's just so afraid to do it. He's going to try the baclofen next. But again, he's in such fear right now.
Yeah. Until the weather calms down, it's probably not a good idea.
New York has been freezing and windy. I'm petrified to walk out the door with him.
It's bad. It was 70 here, and now it's supposed to be a low of 30 in like a day or two, and 45-mile-an-hour winds. So
I've been trying some supplements. That's what I wanted to ask anybody if they're using any kind of supplements. I've just been looking up supplements that help with nerve pains, and I know Alan was on before. I know he's on B12 sublingual.
The regular Super B complex helps for nerve health, and that's what my neurologist suggested. And I also take magnesium, which works like a muscle relaxant, helps. You guys know that.
Yeah.
And
you know what I was wondering? I looked up, I was listening to what Alan had said, and he said he was on 5,000 milligrams sublingual of the B12. I'm trying to research it. I know I've read that it doesn't repair the nerves, but I'm also afraid that it's going to affect the balloon compression in some way, but I can't get that answer.
It might not affect the balloon compression, but it can cause nerve pain in your teeth. Some people are helped by it. It caused me immediate nerve pain in my teeth.
Really?
B12.
Yeah, the sublingual.
The sublingual. He's been giving it to him. He takes a B12 shot once a month.
Okay.
And then I've been reading how B12 deficiencies can affect, with nerve damage and nerve pain. So I said, let me try it. But now I'm wondering if it's going to affect him in a negative way, being that he had the balloon.
Does he have his blood levels drawn? Like he
does. We're just getting the results. We have to get the results this week, so I'll check it out. But I started him on the magnesium bisglycinate, and I'm just trying other things. But I'm trying to find a doctor that will work with me on seeing his condition,
right?
With blood work, I just can't find anybody. Finding doctors is the worst.
Yeah, the naturopaths are your best bet. Kind of through the hospital systems, a lot of times they have, a whole unit devoted to it. How about D3? Is he taking?
He's taking D. He's taking 50,000 milligrams of D3.
So he was low on that too. Of course, anybody above Alabama is low in D, especially.
5,000 probably.
Yeah.
No, he can take 50,000 a couple times a week. If he's really low, he probably was super low. Yeah.
So what is your opinion, Lynn, about the B12? I'm sorry.
I was just, it's interesting because I looked into it too. And I tried the sublingual and it just like electric toothbrushes are just not something you put near rough nerves, and that just really bothered me. Other people that seem like they're helped with it. It's probably determined by what level you are in your B vitamins.
Yeah.
But,
Well, and with this doctor just mentioned with the balloon compression, when he first had, Dr. Brown did it. So thank God we found Dr. Brown.
Right.
And when we spoke to him that evening, because he did the procedure very late, he had said, I didn't want to numb him. So I only compressed them for 1 minute. They can do the compression for up to 5 to 8 minutes, Dr. Brown said. And that worried me. Is that mean it's going to wear off quicker? So I think that's what's stuck in Joe's head right now, that it's not going to last very long. So he's just concerned, but he's not tapering off the medicines. He's just too petrified to do it.
Yeah. Do you go back and see Dr. Brown soon?
We see him June. We could call him at any time. Another doctor where the assistant is amazing, Dr. Brown. We had two video conferences with him, and then when he told Joey get to the emergency room right away, the pain. Now he doesn't have. I don't know if anybody else goes through this. He doesn't have lulls. He was just 8 months of 24/7 pain.
Yeah.
So at that point, and
awesome.
his mental status was not good, and Dr. Brown recognized that and said he wanted to do which he's already had an MVD, failed MVD.
Right.
Now the Fiesta showed a complete other compression under the trigeminal, probably from the original MVD, but that's not being determined. So Dr. Brown recognized that he was under tremendous stress and said, well, then let's do the balloon. He said, your mental stability is not well. So we went with that. And we're a month out, month and a half, but he was in 8 months of 24/7 pain.
It's so hard.
It was very dark and grim for a long time.
Did the balloon help, Rose?
The balloon, he had it February 28th. And like I said, just recently, he started feeling like an ache right here where he normally, the trigeminal nerve pain was happening. So that's why he's so nervous to taper off any other meds.
But did it take the pain away originally?
I'm sorry, Tim, I didn't hear you.
Did it take the pain away originally?
So the first week, I have to say we panicked because he had the same TN pain.
Right.
And then he had the procedure on a Monday. On Saturday, he had pain and we were like, oh God, this didn't work. Now what? And then from that Sunday on, no pain. So we're knocking on wood. No pain he had like a week of definitely triggers and pain. And we were like, what do we do now? And now it's been about a month and a half and we're okay, other than some aching. But like he said, he could take the ache.
Yeah.
But as far as tapering off meds, he's a little nervous about that.
Well, it literally is like PTSD. I mean,
oh my God, it was.
Yeah.
I didn't think I thought I was going to lose him a couple of nights.
I know. I like look at Pete's face. You can see it. The caregivers you take so much weight. You help carry the burden, but it's heartbreaking for us to see you too, because I know it breaks your hearts.
It does.
It's so hard.
Lynn, can I ask you a question on baclofen?
Yep.
Because I know you said you were taking it. I don't know if you're still taking it.
That messed with my QT interval of my. No, actually, Tizanidine did. Xanaflex. The baclofen just makes me really drowsy, but
I don't want that.
Robaxin is what helps me the most.
Okay.
So kind of whatever.
Well, I want to thank you for the lidocaine. Remember you put the little picture up that I got some lidocaine and I have been using that, and that is really good stuff.
Oh, good. I'm so glad.
Yeah.
I just put it in there and just
I put it on a Q-tip and I put it all around in there, and then I kind of do I let it sit in there for a little bit, and then I do a swishes.
Yeah.
Like a mouthwash swish.
Yeah.
Because it can numb the throat,
Right. Yeah.
Stuff's it's pretty potent stuff.
Right.
But
yeah,
it's
whatever
good.
takes the edge off so you can
I
brush your teeth
know.
or eat. This morning I was having oatmeal. I couldn't even chew oatmeal. It's like, come on.
Oh,
It's crazy.
yeah. Yeah.
Spring is just a hard time, I think, for us with the barometric pressure dropping so quickly. And
Yeah, spring has been terrible.
oh, Aaron's mentioning turmeric. Yes, a great anti-inflammatory. Thank you.
Oh,
Erin.
turmeric with pepperin. You need it with pepperin.
Okay.
Because that amplifies it by a lot.
Okay. Great.
So
point.
it's turmeric with pepperin.
With pepperin.
Yeah.
Okay.
My brother-in-law is a pharmacist also, and
that's
he says
so helpful. So helpful.
it is helpful. Yeah.
Like, it amazes me that some of these brilliant doctors just don't know about some of the simple things that can change your life. Like the eardrops, like they're meant for your eyes,
that's a good one. Right.
Geez, when you're desperate, you're desperate.
So
many of us have used, for you new people, Tony, have used opiates to varying degrees over time for constant pain, not the classic, if it comes and goes, it's not applicable to that. But if you fall into the 90% that the doctor was talking about, where the pain is constant and it's some sort of ATN type or TN2 or where it's there all the time, they're tough to get now, but we do have a doctor that will prescribe them here in Detroit, in the Rochester Hills area, if it's applicable to your particular case.
Thank you.
I've been at 600 milligrams a day, but I'm at 240 now. So I've been on morphine for 25 years. So you can develop a physical dependence, but not an addiction, unless you've got an addictive personality.
So some of those medicines that, somebody else is talking? I'm sorry.
No, go ahead, Amy.
No. Some of the medicines that are prescribed regularly need more screening than the opiates. They're harder on your system. They need regular blood monitoring, and it's incredible that they're ignoring that fact because. And now there was an article recently in the New York Times, a couple of times, how they're starting to remember chronic pain. And it was like the last month that, I came across 2 different articles in the magazine section, which is hopeful, but it doesn't get out past that magazine section on Sunday. But yet they're saying they went backwards by following these strict laws because they were afraid of everything. And they don't take into account that a lot of the drugs are illegal that people are getting sick on. The fact that alcohol is killing more people than drugs, or as many. And there's all these different things but the thing that scares me that I tried everything. It made me sicker than pain medicine. It made me more tired. It made me not be able to function. I don't know. But the fact that I saw these 2 recent articles, like in the last 2 months, it's hopeful, but I want my doctors to pay attention to it, like they won't, because they're still just busy day-to-day pain management doctors, and they can't focus on it. They don't want to, because it's still just an article and it's not a law or rule or anything. So
everybody's switched to the
You have constant pain, Amy?
Constant. I mean, the only relief is if I have pain medicine, and they limit that so much, and going to sleep.
And you're
what pain medicine?
Where are you located, Amy?
New York. Long Island.
What's the pain medicine, Amy?
I don't really say online because we're recorded, but
you can stop. Let's just stop. Just wait for a second. I have honey, stop it for a second.
Okay. All right.
Thank you, Lynn.
Recording is resumed.
Got it. Thank you.
Yeah, I just put it in. It's CTFO. That's the name of the company.
Thank you.
You could just try it. I bought a few supplements from them.
I appreciate it. And as far as motor cortex, did Dr. Brown put that in? Is it implanted?
Yes, it's under the bone. And so they open up a section of your skull, take that out. They have to find out, there's a map that they do to figure out where your face is on the brain, so they can figure out where to put the electrode. So that once they find the location, they put that on the dura, not on the brain itself, but on the dura, the covering of the brain.
Mm-hmm.
And then they run the wire down your neck, and then into your chest is where I've got the battery.
You feel okay physically from it? You're good? You don't know it's there?
I don't know it's there. When I first got it, I was sensitive to power supplies and security gates. I was a little leery of when I went to the airport. I think I felt the metal detectors. It was buzzing in my face and like zzz, but
I hope it goes off.
Other than that, I mean, that's nothing compared to I'll deal with that for sure. That's nothing compared to the pain. It works. It works still today. It works great. I mean, I'm probably one of the lucky ones. I did have an infection. I got to say that I had an infection from the first one. It just didn't heal properly from the where they fish the wire through and then have to fish it back down. So I had to have it taken out after having it for 9 months. And then then since it did work, he put it back in.
Because he knew it was working for that. So he just,
yeah.
That's great.
Yeah. But with everything, there's a risk, you just, it was, well,
scary and sure.
The surprising thing that hi, I'm Danielle, Aaron's wife, husband. What am I saying?
His beautiful wife.
One surprising thing Dr. Brown did say, he said it's not that invasive, which I was surprised. I'm like, what? You took a piece of skull out? That's not invasive? But he's like,
right. And
if you don't go through the dura, then it's a lot less risky, I guess.
Yeah, you don't penetrate and leak the spinal fluid. The fluid, yeah.
It's on
good
the
point.
shoulder.
Yeah, it's not like the MVD. The MVD has to go through all of that.
And that's only really if you're seeing TN, but I don't have apparently signs of TN. But I know I have crushed nerves from all the work that was done. That's what I'm sure that's what my problem is, because they've never found any lesions. But I've never had lesions. Can't the lesion be down here? Like, I don't know. They've done cone beam scans, and well, if it hurts here,
I would think that a lesion could happen anywhere. Myelin is everywhere. That's the whole part of the nerve. Yeah,
that's right. And if the sheathing is going over here where I hurt.
Did you have a dental procedure that caused it?
I don't know which one. I had a few, and then I got to the point where I had a root canal because the crown hurt. They took the crown off. They made a new one when this all started, but it may have been old dental work under the crown. And then they took the new crown off and did a root canal and said, sit without the crown for a little while. And it just got worse and worse and worse until I pulled it.
Melody,
that sounds like me.
Yeah.
Yep. And then I pulled the next one because it didn't. And then there was no blood going to the next tooth. There was no supply of blood to the next tooth.
Same here, Amy. And now I've got like a lot less teeth, and still in pain.
Right.
And
I always thought I'd be putting them back in, but no, because.
Well, now you're too afraid to have anything put back in. Yeah, right.
And it's scary that somebody would probably want to try it. It's like.
I know. Aaron, did you have the same kind of thing that Amy and I and Tim with the dental thing, or how did your Aaron? How did your pain? Yeah.
It was 2 weeks after a dental cleaning. That's when I came down with it. It started as a burning in my chin, and then over the course of that day, it slowly worked its way up the side of my face. But 2 weeks before, I had just a dental cleaning, and it was routine.
Right.
And then actually, it was even weirder. About a month before that, I thought I was having a heart attack because I was having numbness on the left side of my body, my torso, down my arm, and it ached.
Wow.
The left side of my arm just ached like a heart attack.
Yeah.
So I went to the ER, and of course they found nothing wrong with me. They said I was fine, sent me home the next day, and I didn't think anything of it. And then
that started.
And then, but that was what preceded even the dental procedure, which was weird.
Right, that is weird.
Yeah, and I just woke up with it. It was a Monday morning at 6:30 in the morning. I just woke up with it for no reason.
Wow.
And this motor cortex helps that. So this is a damage, and it's helping a damage because everything is TN that I read about with.
Well,
I know.
I want to say, I don't know if it'll help a damaged nerve. I remember Dr. Brown telling me that a damaged, like if I had a procedure, like a rhizotomy that damaged the nerve, or glycerol, like glycerol or radio frequency, that it may not help as much.
Well, that's why I brought up to that doctor tonight about damaged nerves. I mean, could
I don't know what
dental procedures have caused damage to our nerves, and we need a different way to
right. So right.
You know what I'm saying? If
right. Maybe
because the pain
I would go back to Dr. Brown about the damaged nerves, and then just consider the opiate route.
But he doesn't.
Anti-seizure.
Right. They want the anti-seizure meds. They did nothing for me.
I've got the anti-seizure too, plus the opioids. I mean, I've got it all
Are they
too.
helping? Is everything helping together, or?
I will say that I do believe that the gabapentin anti-seizure does help. It doesn't help as much as another drug that they. Yeah, I mean, I'm on 3 different things, with the opioids. So, yeah, I mean, the combo does help, but yet I feel like I'm sometimes out of it, a little bit,
Well, that's when I started on all of this years ago with a neurologist. I went through every medicine, everything, and nothing worked because it was a crushed nerve, and it wasn't.
Crushed nerve.
Yeah.
Normally,
when they did the work, they just went through they don't even know what they did. And then they pulled the tooth, and then they pulled the next tooth. Little did I know they shouldn't have been, but nobody's going to tell me to not pull a tooth back then. And the scary part is, I don't want to scare anybody. When I see these commercials for these implants of 4-on-4, or however they advertise them, there's going to be so much more damage in the future.
I thought so too.
Right?
I thought so too. I thought
because
if we're having it with just like 1 or 2, could you imagine having a whole pile of implants?
And they're all new. It's a new procedure, and they're just selling it like free teeth. Going to be great.
Right.
That's what
I'm going to take out my whole upper.
Not up here.
I
don't want to put
one denture.
In here.
They proposed 4 implants, and I didn't want any part of it. So this
I don't blame you.
This whole thing, it's easy to clean my teeth. I just pop it out.
It's a bridge, right? It's a bridge.
It's a whole denture. All these teeth I can pull out and show you, but Pete will probably get upset with me.
Never.
I have a partial in the bottom.
Does it hurt on your gums? Is it comfortable on your gums? Is it?
Yeah, it is. Let me show you.
Wow. Look at that.
The grandkids like this. Now let's put on the video. Scares the shit out of him. And then you use, we're all fans. You use fix it, they call it, to put in that.
And it stays?
You don't have to. You got to have a good dentist like I have. She's got a good lab.
Who's your dentist?
Well, I had Dr. Valoran. Mine was from an infected root canal. And so I'd had a few teeth removed. But then they wanted to do 4, because I have a German jaw, very strong. Pete knows what that is. And they wanted to do 4 implants. And I said,
oh, geez,
take them all out. So Dr. Valoran, who left the state here about 5 or 6 years ago, he was an oral surgeon, and he was giving us our opiates as well. He had treated atypical trigeminal for probably 30 years. He's working for veterans now down in Dayton.
That's nice of them.
That was the alternate I went with, and I'm so happy with it. Every now and then, I'll get a little food up in there or something, and it might cause a little blood on the gum, but otherwise, it's no problem. Now, back to Aaron, I respect what Aaron said, but relative to the peripheral, won't say names. Peter, we got it running?
I can stop it. I'll stop it.